All right, thank you very much. Sorry for the technical difficulties. My name is Bali Yahi. I'm an assistant professor, as Heshi said, in the Division of Infectious Diseases at the University of Pennsylvania, and I'm honored to be the director of the new Penn Medicine program for LGBT health. My area of clinical work and also research is in HIV, usually in the areas of epidemiology. I work closely with the City of Philadelphia Health Department and also with clinics across the country to better understand how HIV-infected patients use care and how to improve the care for HIV-infected populations. And today, I was asked to talk a little bit about caring for the aging HIV-infected population. So I'm going to set the stage a little bit and give you some background about different studies that have been done, where we are right now, and certain issues that us as providers and you as a community and patients and advocates should be concerned about. So the objectives are to understand the epidemiology of HIV in the older population, to describe treatment outcomes for older people living with HIV, appreciate comorbid conditions, which are conditions that can occur with HIV in elderly people living with HIV, and finally discuss some special considerations for caring for this population. So over the last few years, we've been noticing that there's a larger increase in the proportion of individuals with HIV that are older than 50. And really, there's two reasons for this. One is that we're getting new infections in this population. So there's new HIV in folks that are age 50 and older. And also, our therapy and drugs are so well right now that people are living longer. And so the folks that were infected when they were younger are now aging. And so for those two reasons, we're seeing an increase in the average age of people living with HIV. And so this slide really shows this. This is data from a very large set of clinics in North America. It includes those in the United States and in Canada. And there's two lines. The line at the top are individuals that are 18 to 50 years old, and the line at the bottom are those that are 15 above. And this looks at information between the years 1997 and 2007. So you can see that over time, the number of folks that are older than 50 has been rising. So it went from 17% in 1997 to 27% in 2007. And some people estimate that in the next 5 years, we'll probably have half of the people living with HIV will be above the age of 50. Next page. All right. And I think it's important to remember about the other point, which is that we're getting new infections in people that are older, is that just because you're older doesn't mean that you stop having sex. And this slide really shows that. It shows a couple age groups, 57 to 64, 65 to 74, and then 75 and above. And what you can see is that there's a bar for men and a bar for women. So if you look all the way on the right hand of the screen, there's still 38.5% of men that are 75 and 85 that are sexually active within the last year of having this survey done, and 16.7% of women. So I think it's important for us as providers and also as a community to remember that, our patients are sexually active, regardless of their age. Next slide. And so there's a couple other issues that sometimes we talk about as why are older patients getting infected, and these kind of list them. Number one is that many older patients may be newly single. They were in relationships for a long time and a spouse may have died or something, and now they are entering into the dating scene again or something happened. And so they are maybe unaware of some of the issues that are surrounding HIV. There's a belief that maybe HIV only affects younger individuals, and I think that's been also spread through the media by the different campaign ads and various things that are targeted have been mostly towards younger individuals. So there may be a belief that it doesn't hit everyone. Also unprotected sex, especially when we think about women as they age and they enter menopause, the risk of pregnancy is less. And so that is one of the main reasons why individuals use condoms is to prevent pregnancy. And there could be more unprotected sex in this population. And then, like I had mentioned, there's a lack of HIV prevention and outreach that's targeted towards older people living or older people that are at risk of getting HIV. And there's this policy that I like to say is don't ask, don't tell. And so a lot of providers sometimes when they see an elderly individual or someone that's older in their clinic, they may not even ask about this and this doesn't come to their mind. So that's something that we will hopefully do a better job of educating, of, ask your patients about their sexual behavior and their sexual health. It's important. Next slide. All right, there you go. You can actually do one more and one more after that. Okay, this slide shows the CD4 count. So CD4 count is a measure of a patient's or an individual's immune function. It's how well your body is responding to the virus. And when you have a very low CD4 count, you're at risk of getting certain diseases. And when you're higher, you're less likely to get those. And this slide really shows what is the presenting CD4 count. So when someone gets diagnosed with HIV and they come into care and their doctor draws some blood work, what does that number show? And again, these two lines are similar to the lines that I had described before. The top line is for younger individuals, those that are 50 years and less. And then the bottom line, the red line, is for those that are 50 years and older. And you can see that this is, again, the period between 1997 and 2007. So for every single year, people that were 50 and older, their immune system was a little bit weaker when they presented to care with their doctor. And over the last 10 years, in 2007, the presenting CD4 count for older individuals was 266. But if we look at younger people in 1997, it was 269. So even after 10 years, there still hasn't really caught up. So I think that tells us that we have to do a better job of detecting HIV earlier in people that are older. Next. I like this slide a lot because it shows the changing face of HIV, just as we were talking about. This is actually taken from New York Magazine in 2009, and they did a study about kind of the changing face of the epidemic, and they profiled a couple different individuals, and they kind of talked about how long they've been living with HIV and some of the different complications that they're dealing with. But I think it really highlights the fact that as people are living longer with the virus, there's certain conditions that they may be prone to, bone disease, issues with memory, and those are things that we weren't really dealing with in previous years, and I think that's a consequence of the really good drugs that we have. So one way to think about how to approach care for older people living with HIV is in 3 phases. The first phase is early HIV care, which really deals with screening, diagnosis, and getting them started on therapy. The second care is really maintenance, so keeping them on their HIV therapy, but also addressing many of the other conditions that occur when people age. And then lastly relates to advanced care planning. And so those are folks as get older, making sure that you have a goal of cares established and end-of-life planning. So let's talk a little bit about the next slide. The first part. So the goals for treating people that are older or younger with HIV are the same. We want to make sure that we get their virus suppressed and undetectable, and we want to make sure that their immune system is boosted, and we want to make sure that they survive longer. So those goals are the same regardless of what your age are. So I'm going to present a little bit of data of how well we do in accomplishing these goals by different age groups. So the next couple slides talk about that. So the first one looks at how well we do at suppressing a virus by age group. And so you can see that the top group are the top group are folks that are greater than 60 years old, and we're looking at the percent that has a suppressed virus by age. So you can see they do a better job of getting their virus suppressed quickly. The older you are, the more likely you are to drop your virus very quickly in the first 2 years of care. The next one just shows it by the different sort of medicines, because there's different sort of HIV medicines that you can take. There's things called protease inhibitors, and there's another class, long word, NNRTIs. This shows that regardless of the type of medicine you take, it's about the same result. Those that are older are able to get their virus suppressed quicker when they first start therapy. Now, when we look at immune function, which we just talked about, which is a CD4 count, a measure of your immune function, we see that actually folks that are greater than 60 have a slower rise in their CD4 count. So when we start someone young on HIV therapy, their immune system is able to kick in very quickly, and we see larger jumps when we measure them in blood work as we see them, and that is a little bit slower in elderly individuals. And again, this is regardless of the type of medicine that we use, we see the same thing. And this slide really looks at mortality, how that's been changing over time. And you can see is that originally when folks present to care, if they're coming into care very late, most of the reasons why they would have complications and die would be because of AIDS-related issues. But what we're seeing now is that people are living longer and longer, and so the diseases that we would see when someone would have AIDS, like pneumocystis pneumonia, are not as common. And they're just dying of normal things that relate to aging, cardiovascular disease, diabetes, things like that. So to summarize this thing about outcomes, what we found out is that actually older individuals do better job of suppressing their virus quickly. So once we put someone that's 50 or 60 years or older on therapy, they're actually able to get their virus down very quickly, faster than younger individuals. However, when we look at their immune function or their CD4 count, they do a little bit worse. They're not able to get it up as high as quickly as younger folks. And then in terms of mortality, obviously older folks are more likely to die than younger folks, but the reasons are now not related to HIV. They're more related to complications of aging, heart disease, cancers, things like that. All right, so that kind of covers this first part about talking about starting therapy and outcomes. I'm just going to take a brief break. I know there's a lot of information. Is there any questions about that? Yes?
Yes, you mentioned that older people are dying, from natural causes. And I have some concerns about what the effects of treatment are, HIV drugs, and things that we may term as natural causes, such as heart disease, diabetes, kidney failure. I recently heard some information, like for instance, with renal disease and renal transplant, where people who are HIV positive have a much higher rate
Yes.
of failure.
So you're not a plant, because that's actually like my next set of slides, is talking about this concept of premature aging. Are we aging quicker? And so we'll talk about that just in a second. Any other questions? Okay, so let's go into that. That was a perfect setup. So next slide. So this talks about the normal aging process. We just need to remember that as individuals age, your body changes. And so our bodies will lose bone and muscle mass. We'll have decreases in renal function, so our kidneys won't clear things as quickly. We'll have memory loss, and then also something called immunosenescence, which means our immune system is not as strong. So, if you get a cold, it may last a little bit longer. So that's the normal process. And I think next slide will show that as we age, there's more and more issues that individuals deal with. So this group on the left are those 50 years and less, and you can see that about half of them don't have any other issues other than HIV. So these are folks in an HIV clinic. Those 50 years or less have only HIV, and that's what their doctor is treating them for. As they get to 50 to 64 and then greater than 65, there's more of them that have issues, additional issues, such as hypertension or diabetes or cardiovascular disease. And so you can see that the number without any other comorbid diseases decreases, and 1, 2, 3, and even 4 or more other issues that patients are dealing with increases as you age. That's not exactly unexpected. I think as you get older, we start dealing with different issues. And there's a group of conditions called HIV-associated non-AIDS conditions. So these are folks or diseases that occur, such as cardiovascular disease, metabolic diseases, which includes diabetes and high cholesterol, neurocognitive diseases, which relate to memory issues, bone diseases such as osteoporosis, and then malignancy or cancers. And then just another one. And then just as we were talking about, what are these due to? Are they due to HIV? Are they due to therapy? Or are they due to age or some combination? And that's what I'm going to try to present some data on, is that there's actually more likely it's due to a combination of both HIV, aging, and the therapies that we're doing that patients are taking to maintain their HIV. Okay. So this was a series of questions that was asked of, do HIV-positive patients experience conditions 20 to 30 years earlier than those without the infection. So this gets to the issue of something called premature aging. Premature aging is defined as a younger age at diagnosis of an age-related disease. So to give you an example, let's say someone normally gets a heart attack at 50. Do folks with HIV get a heart attack at 40? Is it a younger age that they get a disease? And this is different than increased risk. And so we know that folks with, for example, diabetes are at higher risk of cardiovascular disease. Those don't necessarily occur earlier, they occur at the normal age. That population just gets them more frequently. Okay, next one. And so we're just going to talk about a couple studies. Next one. This one was from the veterans aging cohort. So this is a group of vets, and this is a special cohort. It includes HIV-infected veterans that are seen at VAs across the US, as well as non-HIV infected individuals. And so that's one of the advantages of this study, is that it has both populations in there, so we can compare and contrast. And this study just shows that for the most part, the populations were the same, except that there was a higher level of diabetes, hypertension, and hyperlipidemia, or high cholesterol, in the non-HIV infected group. And this looks at the HIV characteristics of this population. About 20% of them had CD4 count less than 200 or AIDS. Most of them were on therapy. Okay, so these series of slides are gonna be similar, and I'm gonna present them in the same way. So this is looking at MI, or myocardial infarction, or heart attack. So they asked the question, do folks with HIV, are they more likely to get a heart attack at an earlier age than individuals without HIV? And so what this shows is that, on average, those with HIV or without got a heart attack at age 55. So there was no difference. So you can go to the next one. So there was no difference at age in diagnosis by HIV status. So HIV-infected individuals do not experience heart attacks at an earlier age. But then we asked the question, is there a greater risk? Which again means, does this group experience these outcomes more often? And in this case, yes. About 81% increase in the rate of heart attacks are seen in HIV-infected patients than not. Next one. And this graph kind of shows that as you go by age, there's the top bar HIV-infected individuals, the bottom circle are non-HIV infected, and you can see that that circle is above, which means that they have a higher risk. Does that make sense? Am I explaining that correctly? It's a little bit hard to understand. So there's no difference in the premature aging, but they're at higher risk. Okay. So similarly for end-stage renal disease or kidney disease, which we were just talking about, the HIV-infected individuals on average experienced end-stage renal disease at age 58 compared to age 55 for HIV-infected patients. But that difference was not what we call statistically significant, which means after we looked at the different factors, there really wasn't much of a difference. The next thing looks at risk. Are HIV-infected individuals at greater risk of kidney disease? And that answer is yes, about 43% increased risk than those without HIV. Okay? And then that's it. The next slide looks at non-AIDS cancer. So there are certain cancers that are HIV-associated, such as anal cancer, Hodgkin's lymphoma, and then there's others that are not. They have nothing to do with the virus, such as bladder cancer or colon cancer. And so this study looked at both AIDS-associated cancers and non-HIV-associated cancers. And again, using the same format, the average age for those that are HIV negative for HIV-associated cancer was 57.8, and for HIV positive was 54.9, so 55. And for this one, we did see a difference. So about 7-month decrease between age of those that are HIV positive compared to negative. So that means, on average, HIV-infected individuals had HIV-associated cancer 7 months before their non-infected counterparts. And then it was a greater risk as well. So their HIV-infected individuals were at greater risk of these cancers, as would be expected.
Can you explain what you mean by greater risk?
Yes. Yes, it's very complicated. So greater risk means it just occurs more often. So that pretty much is what it means. So if we had 100 people with HIV come into the room, for example, let's say that 50 of them have an HIV-associated cancer, compared to another 100 group of people that are non-HIV infected, maybe only 40 of them have HIV-associated cancer. So it just means that it occurs more often. They're at higher risk, so we see it more often in that population. Does that make sense? The difference between the aging is if we had a group of folks that were, different age groups, we would see a particular condition at a younger age. That's kind of the distinction here. But these are not unique to HIV. So to give you another example, like let's talk about diabetes. So if someone has diabetes, they're at higher risk of heart disease. And so you kind of see those commercials on TV. So that's kind of understood, is that there's certain chronic conditions that make you at risk of something down the road. If you drink a lot, if you have a lot of alcohol, you're more at risk of liver disease. That's what we mean by that, is that if you do something, you're more likely to experience an event. And so here we're comparing HIV infected versus not. Does that make sense? Okay. Yeah.
I was just wondering if it includes any co-occurring factors such as smoking and non-smoking?
Yes, so these factors we adjusted for age, race, sex, BMI or body mass index, so kind of your weight and height, alcohol use, cigarette use, hepatitis C, anemia, and diabetes. So they adjusted for all those because the VA has a very rich data set, so we were able to adjust for other factors. Okay, the next one relates to the other cancers. And again, this is something similar. We'll go through these quickly. Again, there was a 5-month decrease in the median age. So there was premature aging, or folks that are HIV negative, where folks that were HIV infected, on average, had about 5 months decrease in the mean age. And they were also at greater risk. Or there was no difference in greater risk. So again, those slides I just mostly provide as background, and I'll summarize them in a second because they're very complicated. And I think the issues is that was raised by many folks are we, the therapies that folks are on now for 10, 15 years, are there very bad side effects? And if you're living with HIV for a very long time, how is it impacting your body? So these are the first of a set of different studies that researchers across the US are looking at, is let's figure out if it's affecting our bodies differently. This looks at hepatitis C, and so I think what we have learned is that if you have hepatitis C and you're infected with HIV, it actually leads to progression of your hepatitis C. So this is something that we've known for a little bit, is that it accelerates liver disease and some of the complications that you have. And so as providers and as a community, I think it's important to know that if you have hep C, to make sure that we do everything that we can to minimize that. So decrease alcohol, make sure that we consider therapy, et cetera, like that, screening. This slide shows bone mineral density, which is a measure of osteoporosis. And so what we see here is that on average, HIV-infected individuals, and this one is men, have a higher risk of fractures as you age. So I think this is something to keep in mind. We already talked about as the normal aging process. You experience bone mineral loss and you're at risk of fractures. That's above and beyond for folks with HIV infection. Okay. So I know that I just dumped a whole bunch of data on you. We're going to take another quick break to kind of assimilate all this stuff. So I think in the kind of the take-home message is that there's a lot of studies that are going on right now that are looking at what are the effects of the virus and the therapies on as folks age and live longer with HIV infection. And for the most part, there are certain conditions that there's no difference. For example, cardiovascular disease, in this case, heart attacks. People are with HIV or without HIV get heart attacks around the same age. For some things, such as cancer, individuals with HIV may get that a little bit earlier in their life than those without HIV. Yes?
I have a question about these very strong antiviral drugs. Somebody who's HIV positive at 20 they give them a Sospiva, a Pyrobenz, Rayreatas, or whatever, and they have to take it every day until they die for the next 60 years of their life. Is anybody doing studies about what happens to your body, good or, well, good, but bad, that Sospiva or these other drugs might do when you take them for 60 years? Now, I know they haven't been around for 60 years, so I don't know. But is anybody studying this?
Well, that's some of the stuff that I just presented, is that's exactly the question that people are asking is, what's happening as people are on these drugs for a long time? And how does the virus interact with your body for folks that have been living with it for years, 10 years, 15 years? So those are just some of the stuff that I just presented. And what we're seeing is that there is some changes, but in certain conditions there are, and others there aren't. So I think this is an area that we have to continue to look at and work at. But you're spot on, and your question and your comment is what a lot of other clinicians and providers and researchers are very interested in, is what are the long-term side effects of HIV and these drugs. And some of the stuff that I presented, although it's a little bit complicated, is kind of the tip of the iceberg of that this is on the radar, people are interested in it, and they're doing some studies on it. Mm-hmm.
Even in people with undetectable viral load, there is a low level of chronic inflammation. And so what role does that chronic inflammation play in causing the comorbidities? And has anybody thought about possibly treating the
Yes.
inflammation?
I mean, that's a great, you guys are a very well-educated audience. That's a great question. We're learning more about inflammation, not just for HIV, but for many things. And people have been thinking about it, and Dr. Frank, who's going to speak after me, can probably answer that a little bit better than I can. There's certain medicines that help with inflammation. One of them is a cholesterol medicine. They're called statins, like Crestor, et cetera. They actually do help with inflammation. So there's interest now in figuring out, should we be giving those medicines in general to help decrease the inflammation? That's a good question. So the last couple slides that are briefly about some treatment considerations, and I think many folks in the room will be aware of this. So there's certain things that we have to consider. Is one, as people age, their kidney function and their liver function metabolizes things differently. So as doctors and patients figure out on what medicines to start folks on, how to adjust things, that's something to keep in mind, is that your body is changing as you age. We have to also be very aware of drug-drug interactions. So you can get some side effects if you take multiple different type of pills. So we have to be aware of those. There's a lot of older people have been excluded from clinical trials, and so that's something that we want to also address, is how do we understand these different dynamics when there's not a lot of data out there. Next one. This slide just shows the number of medications, and you can see that as people go from 50 to 64 to 65 and above, the number of medicines they're on increases. And so on the far is the dark red, and so you can see about 15 to 20% of people that are 65 and above have 4 or more medicines. Some have even more than that. So as you age, you end up getting more and more pills, and that's important to keep an eye on so that they don't interact with each other. And lastly, I just want to share with you some guidelines, is that the clinical community and the doctors have been really interested in this issue of HIV and aging, and they actually gave some recommendations. And they wrote this report called Treatment Strategies for Clinicians Managing Older Patients with HIV. And if we go to the next slide, it just shows some of you can flip through them. It shows some of the things that they recommend. They talk about starting HIV medicines early, a lot of time regardless of what your CD4 count is. They recommend to make sure that we screen for bone disease, for cancer, and for sexually transmitted diseases. They also recommend that we make sure that we vaccinate folks to prevent them from getting pneumonia or the flu. And then also to make sure that we address some comorbid conditions that we talked about: diabetes, hypertension, mental illness, depression. We can skip this one. Yep, and the next one as well. Okay, and then the last section is really talking a little bit about advanced care planning, so end-of-life planning, and really some of the issues that we should consider. And one of those is the psychosocial issues of disclosure. So who do you disclose your status to? Feeling isolated, lack of support. A lot of elder individuals may be losing loved ones, or they might not have the support that they need. Financial issues as folks transition from working to not working. How do you support yourself? And then end-of-life issues. So those are things that are very important and need to be just discussed frankly between a doctor and a patient. And some of the goals are really to target screening, make sure that we do the right screening, do our best to reduce the number of pills that someone is taking so they don't have to be on a whole boatload of pills, try to integrate care so that we work with all the other doctors and services that an individual needs so that things don't fall through the cracks. Case management, long-term planning, and then advanced directives are very important. So in summary, HIV infection is increasing in the older population, and I think as time goes on, we're going to see a larger proportion of the people in the US with HIV that are older than 50. Compared to younger individuals, a lot of older individuals are presenting late to care, so we have to do a better job of screening and testing and making sure that we get them into care quickly. There's some differences in how they respond, how their body responds to the virus. When we start HIV-infected patients that are older on medicines, they do a good job of suppressing their virus, but they need some help on getting their immune system up. And there's lots of different comorbid conditions that could complicate their HIV that we have to work on. And then, like I said, there's some premature aging that exists, but not for everything. So again, I hope that was helpful. That provided a little bit of background about some of the research that's going on there in the epidemiology. And I'll be around the rest of the evening to talk about any issues that you might have. Thank you.